If your follow-up plan says only come back later, it is not complete. The intervals should match the cancer, the risk, and the years since treatment.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
So, that's the uncompromising reality of effective skin cancer surveillance, right there. Listen, a vague calendar, that's a vulnerable calendar. Figuring out exactly what happens next is literally the most critical decision you can make after treatment. Your follow-up frequency doesn't just come out of thin air. It depends entirely on your exact diagnosis, your stage or risk group, your immune status, the specific treatment you received, any prior cancers you've had, new symptoms, and of course, the years since your treatment. It's highly personalized.
Okay, I totally hear you on that, but what does a complete follow-up plan actually look like in the real world? Because, a lot of people just get their stitches out and are basically told, all right, schedule a regular checkup for sometime next year.
Right, exactly. And to close that gap, we first have to know what it is we're actually watching for. It's like a giant puzzle, and the first piece we need to define is a recurrence. A recurrence simply means the treated cancer has returned. That could be right at the original site, maybe nearby, in a regional lymph node, or even elsewhere in the body.
Now, notice the absolutely crucial contrast between a recurrence and what we call a new primary. A new primary is exactly what it sounds like, a completely new, totally separate cancer. It is not a spread from your first tumor. To put that into perspective, let's say you had a basal cell carcinoma, or BCC, on your shoulder. If 2 years later you develop a BCC on your forehead, well, that's almost always a new primary. Your skin is essentially just demonstrating a susceptibility to making more of these keratinocyte cancers.
And finally, we have NED, which stands for no evidence of disease. Basically, this means no cancer is detectable after your treatment. But, and this is a massive but, NED does not mean your future risk is zero. A clean scan or a clean physical exam is incredibly reassuring, for sure, but it absolutely does not mean your skin surveillance permanently stops. You can't just drop off the radar.
So, let's see how all this builds an actual, concrete calendar. The starting ranges shift drastically based on your exact diagnosis. For a routine basal cell carcinoma, starting with exams every 6 to 12 months for 5 years is pretty typical, and then you move to at least yearly exams for life. But for cutaneous squamous cell carcinoma, or CSC, we keep the low, high, and very high-risk schedules completely distinct. A low-risk CSC, that usually means visits every 3 to 12 months for the first 2 years. But a high-risk CSC tightens that window considerably, typically every 3 to 6 months for those first 2 years. And a very high-risk local CSC, that remains every 6 to 12 months for life, even after that closer early schedule. Then there's melanoma, which is determined largely by stage. Stage 0 is yearly, while stage IA to 2A requires exams every 6 to 12 months for 5 years. But more advanced stages, like IIB to V, start much tighter, every 3 to 6 months when there is no evidence of disease.
When you zoom out and look at the big picture, the lifelong roadmap looks kind of like this. The first and second years are intentionally dense. You're going to have frequent visits. Then years 3 through 5 start spacing out a bit as your immediate risk profile lowers. And finally, after 5 years, you generally shift into an annual maintenance phase. Notice how skin surveillance never drops to zero? The frequency safely decreases as you move further away from your treatment date, but it's a lifelong commitment.
They might be wondering, why is that first 2-year window so crowded? Well, let's look at the evidence. In a really robust 4-center study looking at 5-year outcomes for 598 surgically treated CSC excisions, there were 40 local or nodal recurrences. And out of those 40 observed events, a staggering 96% were detected within 2 years. The median time to a local recurrence was just 9 months. So yeah, that is precisely why a high-risk squamous cell carcinoma simply cannot receive a vague, just come back sometime next year plan. It's way too risky.
But that longer, lifelong clock matters just as much, particularly when we're talking about melanoma. If we look at a massive population-based cohort, we're talking 152,811 survivors of a first non-metastatic melanoma. The data showed a 3.9% chance of a second primary melanoma by 5 years and a 6.7% chance by 10 years. So melanoma follow-up really relies on 2 completely distinct clocks, one watching for a recurrence based on your initial stage, and the other watching for a brand new melanoma for the rest of your life.
Okay, let me jump in here. With all this intense focus on recurrence risk and these strict timelines, would a standard physical examination actually be enough? Or is routine imaging, like getting those full-body scans, appropriate if you want to truly be safe?
That is the absolute perfect question to reset our focus here. Because honestly, more scans are not automatically better. Routine imaging is actually not recommended for asymptomatic stage IA to 2A melanoma, and it is certainly not automatic after a low-risk keratinocyte cancer. Selected higher-risk patients might receive time-limited imaging, sure, but generally, false positive findings can lead to a whole cascade of unnecessary radiation, extra costs, and downstream procedures. Instead, the real focus has to be on the anatomy of a highly useful clinical visit. A proper checkup is so much more than just a quick glance at the surgical scar. Your clinician should comprehensively review your original cancer details, visually inspect and deeply palpate the treated site, feel your regional lymph nodes when relevant, conduct a full-body skin check to hunt for new primaries, assess any new symptoms like numbness or pain, and review any long-term treatment effects. It's the whole shebang.
And this level of precise detail is exactly why your exact pathology matters so much, especially when dealing with rare tumors. Take atypical fibrosanthoma, or AFX, and pleomorphic dermal sarcoma, PDS. They are related rare tumors that sound pretty similar, right? But they require completely different intensities. A specialist guideline recommends clinical follow-up for AFX every 6 months for 2 years. Meanwhile, PDS behaves much more aggressively and requires way closer follow-up, often every 3 months for 2 years, plus lymph node exams and selective imaging based on risk. You just can't treat them the same.
Basically, rare tumor simply cannot be forced into your standard BCC or melanoma schedules. It just doesn't work. For example, dermatofibrosarcoma protuberans, or DFSP. That requires incredibly careful scar palpation because a firm change under the surface matters, even if the skin above it looks perfectly normal. Extramammary Paget's disease requires a highly multidisciplinary care team, often involving urology or gynecology, and visits every 3 to 6 months for the first 3 years. And if you ever hear the phrase adnexal carcinoma, you absolutely must ask for the exact subtype, like microcystic adnexal carcinoma or sebaceous carcinoma, because each one of those demands a highly customized, diagnosis-specific surveillance plan.
Right, okay. That covers the clinical office visits really thoroughly, but what should patients actually be doing at home between those scheduled appointments? Like, what are the specific red flags that mean they shouldn't just sit around and wait for the calendar?
That's a great point. Professional visits are really just snapshots in time, right? You, the patient, contribute the missing element of continuous observation. So do not wait for your calendar date if you experience any of these specific call sooner triggers. We're talking about a new or clearly changing spot, a non-healing area, recurrent bleeding or crusting, a new nodule right in or beside your scar, persistent pain or numbness, weakness, or a new lump in a nearby lymph node area. If literally any of these occur, call your clinician immediately. Don't wait.
Now, between those visits, you should also be actively maintaining what we call layered prevention. Sunscreen is an incredibly proven tool, but listen closely. It is not permission to just extend your sun exposure. The evidence-based layers go like this. Number 1, utilize shade, wear protective clothing, and put on a broad-brimmed hat. Number 2, apply a broad-spectrum, water-resistant SPF 30 or higher on any uncovered skin. And number 3, strictly avoid all indoor tanning. No exceptions.
Now, you might have also heard about a supplement called nicotinamide floating around. It's vital to know that nicotinamide is for selected patients only. In the definitive trial, the clinical benefit was shown specifically in immunocompetent adults who had at least 2 keratinocyte cancers in the previous 5 years. A completely separate trial in solid organ transplant recipients, it didn't show that same benefit. So it is a highly targeted intervention. You really need to discuss it carefully with your clinician, and it's limited strictly to patients whose history resembles the trial population. It is not just a universal daily vitamin for everyone.
So how on earth do you pull all this information together into something actually actionable? Well, you build a concrete 1-page follow-up plan checklist with your doctor before you ever even leave the treatment phase. Make sure you literally write down the exact cancer and risk level, the clearance method they used, the exact date and reason for your next visit, what that visit will actually include, the specific symptoms that shouldn't wait, your prevention steps, and most importantly, who owns the plan. If you've got multiple doctors involved, you need to know exactly who is watching the skin versus who is watching the lymph nodes. It's absolutely essential.
You really have to empower yourself with these specific details so you never, ever have to settle for a vague, just come back later. Dr. Hacker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. I'd highly invite you to read the full explainer article at Skin Trust. Use it to discuss your individual decisions with your treating clinician and start building your complete, individualized follow-up plan today. Because when it comes to skin cancer, knowing your exact timeline isn't just scheduling, it's survival.